Everybody, and welcome to our webinar series, Breastfeeding in General Practice. My name is Marie Cantwell and I work as Professional Coordinator for General Practice Nursing, based in Dublin North here. Part of my role is to represent GP nursing on various committees and working groups within and without the HSE, and one of those groups includes the Infant Feeding Committee in Dublin North City and County. A project undertaken in 2022 by this committee devised a survey to explore the breastfeeding knowledges, attitudes and practices among general practitioners and general practice nurses across our area in Dublin North. That survey report has been published and the link will be available in the resources attached to this recording. The survey has been replicated at national level and we look forward to those findings. The results of the study that we undertook identified a gap in knowledge and a need for educational resources for GPs and GPNs working in primary care in order to help them to support, promote and protect breastfeeding. That resulted in this series of podcasts. In response to the request from GPs and GP nurses to have access to practical GP-focused learning provided at a time and place easy to manage, taking into account your workloads, we developed this series of podcasts and their associated live sessions, which were broadcast in the first quarter of 2024. Each podcast features an interview with experts from the maternity services, general practice and the community services. We were extremely grateful to the fabulous actor, writer, director and presenter Stephanie Preissner, who facilitated these conversation-style discussions around the various topics and really opened up those dialogues in a way that's, I think, really easy to listen to and full of information. Following on from the live sessions and the associated question and answer sessions, our group of experts developed a resource list for your convenient use and practice. This includes links to information for you and signposting to support for your patients. You can see this list in the video description underneath this video clip. This is the first in a series of 3 webinars focusing on breastfeeding issues for GPs and GP nurses. Accomplished writer, director and actor Stephanie Preissner talks to Marina Cullen, midwife and IBCLC in the Rotunda, Dr. Sarah O'Connell, GP in Eden Park Medical in North Dublin, and Ailish O'Sullivan, the LESH League Leader and Professional Liaison Officer as well as IBCLC. They talk about a range of issues including milk supply issues, dealing with pain, baby positioning and mastitis. Hope you enjoy.
Welcome to this session, this webinar session. We have 3 members for you on our panel: Marina Cullen, Dr. Sarah O'Connell and Ailish O'Sullivan. And we're going to be talking about commonly presented breastfeeding challenges, things that might arise and tips and tricks to overcome them. So we will start with Marina Cullen. If you want to just give us a line or two about who you are, some context, and then we'll start with some questions.
Sure, Stephanie, thanks. So my name is Marina Cullen. I'm one of the lactation specialists here in the Rotunda Hospital. I'm a nurse, a midwife and an international qualified board certified lactation consultant. My post here in the hospital is in a full-time role supporting women breastfeeding, and I do feel passionate about supporting them to reach their goals through education and skilled support.
Brilliant. I'll stay with you and we can introduce the others as they begin their questions. I guess we'll talk about supply first of all. How can people tell if their baby is feeding and getting supply or they're just nuzzling at the breast?
Okay, that's a great question. And I have to say, when I started here first as a student midwife, I thought if a baby was at the breast and moving their mouth that they were feeding, but I soon learned that there's a little bit more to it than that. So they have a very distinct pattern when they're drinking properly. So when a baby starts to feed, they would have fast, shallow bursts of sucking, and that's called non-nutritive sucking. Very quickly, that changes into slow, deep bursts of sucking and swallowing. And we would get mums to look and listen for swallowing to make sure, because swallowing is the biggest indicator that milk is transferring to a baby. With colostrum, the mum won't hear swallowing, so we get her to look for swallowing in the throat or around the temple. And so most, as I said, most of the feed would be long, slow, deep bursts of sucking and swallowing, intermittently fast bursts again. But when the slow burst stopped, the baby has stopped actively drinking at the breast.
Okay, great. And how then do you know if they're getting enough?
Okay, so with several ways of telling. So a baby, first of all, should be feeding at least 8 times in 24 hours. It is much more likely that they'll feed 9, 10, 11, or even 12 times in 24 hours. That's very normal baby behavior. Any baby that's feeding less than 6 or 7 times in 24 hours will probably get a little bit of advice around that. Other ways is what goes in has to come out. So we'd look at their output. On the first day, we're just looking for 1 wet nappy, 1 dirty nappy, and then incrementally that goes up. Around day 3, that the dirty nappy, the meconium, should really be gone and transitioning to a kind of greeny poo. But from day 5, and when mum's milk supply is really increasing and baby's drinking really well, we're looking for about 6 to 7 heavy wet nappies, clear urine, and the poo then has gone to a yellow seedy colour. And there should be about 2 to 3, more likely 3 yellow seedy poos in a 24-hour period, up to about 6 weeks. So there's a lot of information out there on social media saying that breastfed babies don't poo that often. That's not true in the first 6 weeks. We would be looking for at least 3 yellow seedy poos in a 24-hour period. Then is the baby alert at the breast when they are doing and drinking properly, like I discussed before, long, slow, deep bursts of sucking and swallowing? And the colour of the baby, is the baby jaundiced or sleepy, or is the baby really active at the breast? And is breastfeeding comfortable for mum? So it should be comfortable, and no pain during feeding. A pull or a tug is a good sign, but no pinchy pain during feeding. And the shape of the nipple when the mum comes off, it should be round and not giving a pinched appearance. That would indicate that the baby had a good deep latch at the breast. And then hearing that swallowing after day 3 is a good indicator as well.
And so if baby is not getting enough and we think how can we increase our supply, and is that the only issue that it might be?
I suppose we'd look at baby and look at mum to see, do a little bit of investigative work there. So for the baby, we take a full history. Is this a term baby? Is it a late preterm or early term baby? Those babies, they would tend to be a little bit sleepier at the breast. They mightn't have that buccal fat in their mouth to hold on to a latch and feed well, or they might have low energy reserves. Is it a jaundiced baby? Is there any restriction in the tongue? So we take a full history and look at the baby to see what's happening. And then with mum as well, are there any risk factors for her supply? So we'd start with a detailed history when her onset of menses. Did she have an early onset of menstruation, and did she have regular periods? If she had irregular periods, it's after the ovulation part of the menstrual cycle where progesterone is laid down, and that can really increase the breast tissue supply in the breast during puberty. So there might be flags for supply later in life if there's any delay with menstruation. Also, did she have breast tissue changes during pregnancy? That's a really important question. If not, it would be important that we kind of flag and know that this mum might need a little bit more support. Did she have any breast surgery? Has she had an augmentation or a breast reduction? Both can impact milk supply. Then looking at her hormonal history, does she have any thyroid problems, infertility that might have had hormonal causes? And then doing a physical examination with mum's permission as well. Does she have any indication that she might have hypoplasia? So we'd love to see, is there any widely spaced breasts or marked breast asymmetry or bulbous areola? Again, these are women that we should know to give more support to, and if a baby's not gaining weight, we really need to support these women more.
Okay, and what is the best way then, I guess, to supplement and get that supply up if we know that there's no underlying medical condition, having done those checks?
Okay, so we get back to basics. Skin to skin with the baby. Laid back breastfeeding is just an amazing way for the baby's innate feeding reflexes to kick in. The baby starts to smell, on the areola, there's these Montgomery tubules that smell like the amniotic fluid. So smell is the kind of precursor. It's the first part of feeding. They get the scent, they get interested, and really keeping the baby interested in feeding. Those basics. Have what we call baby moon. So mum and baby and, support persons just spending some quality time together and just focusing on the feeding. Let everyone else do everything else for them. The housework, the cleaning, good support in place is really important as well. And at the very beginning, we're talking about early, frequent and effective feeding. So we want this baby feeding at least 10 to 12 times in 24 hours. and feeding effectively. Responsive feeding as well. So the baby, I would say, as much as blinks at you offer the breast, it's a good way to get started. And to support then, if the supply is low, complement what the baby's doing with start with hand expressing. So we had hands before we ever had pumps. I mean, pumps certainly have their place, but getting back to basics, a good technique with hand expressing can increase the mum's supply. And also giving the baby that extra fuel might increase their effort at the breast as well. And then giving that extra milk afterwards. If a mum is exclusively expressing for her baby, if she's separated from her baby, we have to think of that separation as well. So the stress of that, you know, any techniques, guided relaxing music, picture of her baby, scent of her baby, maybe covering the bottle if she's expressing with socks that she can't see what's going into the pump. You know, practical and emotional support is really important as well.
And if someone is, like you're saying there with the sock, only managing to pump a small amount, is that an indication of low supply, or could it be the pump?
So yeah, that's a great question as well. Is it mom again? Are there any of those flags that we discussed a few minutes ago for her supply, or is it the pump? So if this mum is engorged and she sticks the plastic pump on her breast, that breast is not going to respond, you know, with the oedema. So we'd manage the oedema first. We'd prepare the breast for the pump. A little bit of hand expressing, reverse pressure, softening. Let's get rid of that oedema first, and then start a little bit of hand expressing, and then we can put the pump on. And flange size is really important, that we've got the right size flanges for, you know, any little bit of research that's been done on this has shown that the average nipple size is anywhere between 15 and 17 or 17 and 19, the two small studies that were done, millimeters. And for some reason, lots of pumps come with a standard 24 or 26 size flange. And, you know, we're setting up for failure at the beginning. If it's an ill-fitting flange, the flange should be comfortable for mum, and it should be a good fit.
Thank you so much, Marina Cullen. I'm going to move on now to Dr. Sarah O'Connell. We're going to talk about, like we're saying there, the flange, like all of the comfort and discomfort that mother might feel when breastfeeding. Do you want to just give us a quick line to introduce yourself, and we'll get through the questions then?
Yeah, hi, my name is Sarah O'Connell, and I'm a GP in Eden Park Medical in North Dublin. My personal interest in breastfeeding comes from my own experience, because I thought I knew everything about breastfeeding. I had all the confidence / arrogance of a medic, going, yeah, this is going to be a breeze, you know, have a baby, feed it, raise the perfect child. Bit by bit, I've been learning that none of those things are as easy as I planned. But yeah, I think just listening to Marina speaking about all the challenges, I think I had every one of those along the way. And I think that has given me a really strong wish to help support women throughout their breastfeeding journey.
Thank you so much for that. How, and some of these questions are personal as well, because I have had my own experience. How can women, it's so tiring. And I think at some point, some women are like, I'm too tired. I cannot keep this up. It's very painful. What can women do in that situation?
Okay, so I suppose the first thing to say is breastfeeding is a skill. We have this idea that it's something innate that we should be able to do as mothers. Absolutely not. You know, I mean, for some women, maybe they have this fortunate innate ability to produce lots of milk and they have a baby who feeds easily. But for most of us, it's really, really hard. And I think acknowledging that with women, I think women put a lot of pressure on themselves. A woman who's breastfeeding has already decided that they want to give their child this start in life. And the pressure is already there. You don't need a health professional telling you, you must do this, you must do that. What we really need is kindness and gentleness and support. And Marina was mentioning the importance of support. And that's a massive part of it. I think as a new mum who's trying for the first time to breastfeed, your job is really establishing breastfeeding. And self-care is part of that as well. But really, all other jobs need to be pushed to one side. So as Marina was saying, you know, the housework, the cleaning, even minding the other children, you need help for this. You cannot do it on your own. And I think allowing mums to think, oh, this is desperate. I got really good advice from a friend of mine who, I think I was doing a Zoom call mid-COVID on my first child, going, oh, I can't do this. I said, never quit on a bad day. Now, I had so many bad days, I never got to quit for the first few weeks. And then by the time I had sort of started to think about it, I was like, oh, okay, I'm maybe getting somewhere with this. But
and when mothers say that it's very, very painful, is that just like, yes, it's painful, we need to push through and it won't be anymore? Or is that an indication that something is wrong? And how can we know the difference?
So it shouldn't be painful. I mean, I think the first week or two you may have stitches, it might be awkward sitting to feed baby. This way the laid back feeding might come into its own. But you know, even getting a position, being in pain with hunching over, your shoulders are sore, your breasts are sore, your nipples are sore, everything's leaking, you're sweating, you're tired, and you have this small person who's needing you and you can't provide what they need. So all of that, I think, contributes to the pain, but the latch itself should not be painful. And I think I was a good 6 weeks into my journey before I felt my daughter feeding properly. I went, this is what it's like. It's not painful. It shouldn't be. So if there's pain, there's a problem. And I think that's where you need support and where you need somebody who has experience. You know, it's fine and well looking online or going to your antenatal classes, but I don't think that's adequate in terms of getting a proper latch with your baby and having the experience with somebody like a lactation consultant, public health nurse, one of the experienced midwives, nurse on job, wherever you're having your baby, actually there with you physically. So I went to my antenatal classes and like, you can hold like this, you can hold like that, and we had a baby doll, and it was nothing like the real thing. You know, you really need that experienced hand guiding you through this. I think it's virtually impossible to do it without.
And if it is painful, I know that sometimes a lot of things that is a lot of the reason that's thrown around is tongue tie. How can you get someone to diagnose tongue tie? Like I know with my own daughter, 2 lactation consultants said she didn't. Then an osteopath said that she did. She didn't in the end. But how can you know what is a tongue tie and when it needs to be addressed?
Okay, so again, it's not straightforward. It's not the easiest thing, certainly as a GP, to pick up. I would defer to my lactation consultant colleagues on this, but in my experience, looking isn't enough. So, you know, the reason the tongue is important is because when we suck, our tongue is moving. So if you try now to suck and create a kind of a drinking reflex without moving your tongue, it's virtually impossible. Our tongue is attached to the bottom of our mouth with a little piece of material called a frenulum. And in some children, this is tighter than in others. So the first thing is the baby will not be able to create a good latch. So the latch will be painful. When you're looking at your baby thinking, well, is it painful because it's tongue-tied? I don't know. And one of the things that can be useful is looking at the baby. Again, I think you probably need the experienced support of a lactation consultant with this. Most GPs were not good at it, we're not trained in it. But sometimes looking at the baby when they're crying, and they will be crying if they're hungry, the tongue may not be coming out of the mouth. It might be creating a curved shape, like almost like a bowl shape, instead of, you know, a tongue that's protruding as they cry and look at the breast. But these are quite subtle things. Sometimes the palate can be arched. I mean, I think the really useful things is baby weeing and pooing. You come back to that, because a tongue-tied baby will not be draining the breast, and the breast won't be filling if they're not draining. So it's how baby is doing. Is baby feeding well? Is baby getting enough nutrition to provide wet and dirty nappies? And in the case of a tongue tie, there may be a tongue tie that's not causing these problems. And in that situation, maybe nothing needs to be done. Maybe it's changing the latch, maybe it's improving the latch. Maybe my expert colleagues would have something to say on that.
We'll move on. I'll ask you another question and we can answer that in the Q&A afterwards. What about position for mom feeding? I know that I had like shoulder pain and then my stitches because I had a C-section. What's the advice there before we finish up?
Well, I think it is okay to have pain relief. I think getting yourself the most comfortable position that you can. There must have been 40 pillows around me at one point and I still couldn't get comfortable, and I was like knocking things out of the bed and I thought I was going to, you know, baby was going to fall asleep under a cushion. So for some people, it's a comfortable chair and sitting upright can be easier. It really does depend, I think, on the baby, on the mom's breast size, and what feels good. I also remember using those, you know, the kind of the tray things, and I had like the remote control in one pocket of it and my phone in another, and I had the baby on top of it and everything was falling off. I think it's very individual, but a ring cushion certainly for stitches, you know, the ring cushions for hemorrhoids, they can be quite helpful to sit on if you're really discomfort. Usually that passes after the first week or so, but it is okay to have simple pain relief and not to be afraid to ask for it.
And then finally, about mastitis or blocked ducts. How can you know if you have mastitis or blocked ducts, and what's the next protocol then?
So I suppose blocked ducts are common if baby isn't feeding, and you'll notice it as a feeling of fullness or soreness in the breast. Mastitis is kind of the next stage, and as medics, where we would be concerned is really, if a woman is unwell, so if they have a fever, if they're feeling fluey, the stage before that is really about kind of compressing the breast using cold compresses. For some people, it's warm compresses, and paracetamol, trying to rest the breast. It's okay, you don't have to keep pumping through. I think there's a theory that you have to continuously pump or it's going to get worse, but it's okay to give the breast a little bit of a rest, feed from the other side, maybe gently hand compress the side that's causing you bother, and just give it a bit of time to recover. Breast milk will come back.
Thank you so much. We are going to move to that, Dr. Sarah O'Connell. We're going to move on now to chatting to Ailish O'Sullivan from the Leis League. Ailish, do you want to give a quick introduction about yourself, and then we'll get to your questions?
Thank you, Stephanie. Yeah, I'm Ailish O'Sullivan, and I am a Leis League leader for the last 15 years. And my role in the Leis League is I'm a professional liaison officer. So I organise training for my colleagues and organise also webinars and seminars for health professionals. And I'm also an IBCLC.
And you are a wealth of knowledge. You helped me through my own breastfeeding journey, which was quite difficult.
It was a privilege.
We're going to talk about the challenges in later stages of the breastfeeding journey. What do you do when a baby who's older is kind of distracted during feeding?
Yeah, it's babies. We talked earlier about the smaller baby. Babies are always evolving. And as they get that little bit older, they get so curious about the world. And at about from 4 months on, they really get distracted by what's going on around them. And sometimes what mothers do is they go into a quiet room, perhaps, and just take the baby away from where the stimulus is, or darken the room slightly. What's interesting at about 4 months, which I'm always fascinated by, is that our prolactin levels level off a little bit, and it coincides with this developmental stage for the baby. And what I often say to moms is just to be aware that the baby is still going to the breast enough that it keeps your production up, because sometimes you can have that distractibility phase coinciding with that leveling off of hormones. And that's often when mums will come to us and say the baby's weight is falling or whatever. So it's this phase to be very conscious of, and to just really watch that you're getting in the number of feeds. Sometimes it also coincides with a period of increased waking at night. And that's often the baby's way of making up for those lost feeds during the day and catching up during the nighttime. But we'd often say to mums, look, keep your baby interested, use your hands on the breast, feed from both sides, take them into a quiet space if needed, but just again, keep an eye on the production.
It might also be a time that parents are like, oh, I think my child is now interested in my food. Can I wean early? What is your advice on starting solids?
Yeah, what's recommended for solids? And it used to be much earlier. If you look back at history, I mean, babies got solids at ridiculously early times. But now it's around the middle of the first year, so around the 6 month mark. And what we look for is that readiness for solids, so that babies can sit up with a little bit of support, that they also have to lose what's called a tongue thrust reflex. So when you put something in the mouth, it's a safeguarding reflex for young babies. So you put something in the mouth, the tongue automatically pushes it away to protect the airway. So around the middle of the first year, that reflex disappears. So in that way, you could imagine that the babies then are willing to accept something in the mouth that isn't a breast. So, and again, it's little morsels. Earlier solids has been linked to gut issues in later life. So as much as possible to hold out. And sometimes what people interpret as signs of being ready for solids actually isn't quite just that, like increased waking at night, feeding a little more, all of that isn't necessarily a sign of readiness, and it is possible worth waiting till around the middle of the first year. And then we always see those babies that have no interest in solids until maybe 7 or 8 months. So babies are, again, very individual.
So we have a couple of minutes left, and the next 3 questions that I have for you, Ailish, they're all kind of similar. So I'm going to give them to you in one go, and you can kind of answer as you feel. So one is a question of like, how do I wean? How do I stop breastfeeding? Sometimes you need to wean quickly, and then for other mothers, they find out they're pregnant again, they're still breastfeeding. How do you manage a toddler when the new baby arrives? Or people who are then returning to work, but they're not ready to start breastfeeding.
Yeah. Okay, let's go with the work one first. Like, we find now that with extended maternity leave, and a lot of the mothers that come to our meetings are still very invested in their breastfeeding when their maternity leave is over. So the legislation has now changed. So mothers are entitled to an hour either to pump or to feed their baby or to leave the workplace early to facilitate breastfeeding. So it is more possible than ever to combine breastfeeding with working. And what tends to happen, which is a really good thing, is babies become less unwell from the creche, or if they do get any little illnesses, because they're breastfeeding, they recover quicker. And so less work days are lost by the parent if they continue to breastfeed. Now, with, of course, the elongated breastfeeding, or, society doesn't really understand that breastfeeding is a normal process until well into the second year, and the WHO recommends breastfeeding to 2 years and beyond. So often in that time, many mothers can find that they're pregnant again. And if they do nothing at all, about 40% of babies will wean during pregnancy. But of course, there are those babies that still will nurse, and then new baby comes and you have the toddler. So it is a bit of a juggling act. Sometimes really what the toddler is looking for a lot of the time is reassurance that they're still loved, that this new little person has come into their world is totally upside down. Sometimes they will actually, if they're still breastfeeding, they may breastfeed a little more. If they're not breastfeeding, they actually might ask to nurse again just to try it out, because mum is spending all this time with this new little person. So I want to see what this is like. So there's a lot of negotiating. There's a lot of, if there's another adult in the house, getting time for you and the baby. That daddy or the other mom or the other partner takes baby off the playground, and look, you're such a big girl that you can do this and the baby can't. So there's a lot of talking, a lot of preparing, a lot of negotiating, and a lot of, we would see a lot of moms at La Leche League who will feed into a pregnancy, keep an open mind and not to panic, I think, is important, and then may or may not choose to tandem nurse. So, we would see quite a bit of that. Now, the weaning depends on the age of the baby. That sometimes if a mum finds that she's unwell or needs medication, first of all, it's important to explore, is the weaning really necessary? And I know you've talked earlier about medication. The important part is if the baby still needs milk in the first year, so to introduce another source of milk. The other part, if it's, say, into toddlerhood, is to do it gradually, because the mother's body has got used to producing milk, so that even if the milk is being given to the baby, perhaps the mother is on a very toxic medication or something, so the milk cannot be used, but still to taper off gently, to remove some milk, just even bare a minimum of milk to keep the breast comfortable, because the body will still be in production mode. But also with the older child, just to talk to them and say, look, the milkies aren't working, whatever it is, and we're going to stop now. But just the babies then will need a lot of reassurance, because they find so much pleasure, relationship and reassurance in the breast. So it has a big significance for them.
Thank you so much. And then I'm going to finish up by just asking all of you when, where and how to seek lactation consultant advice. So you can fight amongst yourselves there.
Sarah, you're muted.
Oh, sorry, Sarah. Sorry. I'm going to unmute you. I can't unmute you. Can you unmute yourself? Yes.
Gone again. Yes. Okay. Sorry. My answer was as soon as possible to that question. if I had known how difficult I would find it all, I would have had the lactation consultant holding my hand in the delivery suite. I just don't think that there is, unfortunately, in the hospital setting, enough time, or maybe I was unfortunate. My daughter was born over a bank holiday weekend, but I certainly left the hospital without feeding having been initiated, and I didn't. It took several weeks of tears and heartache to get to where I needed to be. So I think as soon as possible, I think that it should be something that's highlighted during the antenatal period, that women are advised, if you do want to breastfeed, this is how you get help and this is where.
Okay. And Marina, your answer on that one?
Yeah, I'd agree with Sarah there. The antenatal period is the best time to start. And if you anticipated problems, we do have a good clinic here, and I know this will be discussed in one of the other podcasts, a wraparound clinic where you get extra support put in place. Just having the antenatal period, I think, is a really important time to start. And then afterwards, any of those flags that we discussed, that maybe, if baby's not having enough wet and dirty nappies, or feeding is painful, as soon as possible, really.
And Ailish, how can people go about getting help?
Yeah, I'm going to raise the flag for the voluntary groups and community groups, because I think going to a support group and a community before the baby arrives, you see a lot of breastfeeding in action, because in a society where we don't see much breastfeeding, that is so important. And you also hear about the common challenges that aren't necessarily medical issues, but that can be dealt with in the community, peer-to-peer support, watching how other mothers do it. I hold my baby like this, maybe try that. Try this if it helps. Feeling that you're not alone in this really, really important part of your life, I think, is really, really important.
Thank you so much, and thank you to I hope that was helpful to those of you who are listening and watching. That was Dr. Sarah O'Connell, Marina Cullen, and Ailish O'Sullivan. And we will leave it there and go back to the panel.
Thank you.